Welcome back everyone. I hope you've had an amazing week. My name's Dr. Daniel Follows. I'm a GP living and practicing in the UK, and this is GP Made Easy. So this channel covers common medical topics in primary care and also some of the newer healthcare roles that are available in primary care for us and for you patients as well. So as you can see for today's video, I'm dressed in a bit of outdoor gear because I've actually been outside the studio this time interviewing a social prescriber to help you understand more about them and what they do. But before we go into that, don't forget to like, comment and subscribe. Lets me know that you're enjoying this content, so I'll keep making more of it. But anyway, let's crack on with the video. So again, I just wanted to say thank you for coming on my channel. And before we start, you could just introduce yourself and your job role.
Yeah. Okay. So I'm Charlene Rees. I'm a social prescriber link worker for North Walsall PCN, which is the primary care network. I also am a senior social prescriber link worker, and I cover North, East 1 and South 2. My PCN is made up of 10 GP practices. East, where I also cover, is made up of 8 GP practices, and South 2 is now 5 GP practices.
Wow, so that's a big area that you cover.
Big area altogether.
So the purpose of today is just to ask you some questions, just to further understand the role of a social prescriber and what you do to help GPs and other healthcare professionals as well, so patients get the appropriate referrals and you guys get the appropriate information that you need. Is that alright?
Yeah, that's absolutely fine.
Yeah, so first of all then, what is a social prescriber?
So a social prescriber is a non-clinical staff member. We provide support to patients who have health issues or anxiety, depression that may be impacting on their health and well-being. So for us, it's about identifying the root cause or the trigger of their health anxiety, or social issue, and then working with that patient to come up with a solution and hopefully move forward and better improve well-being going on.
So it does focus on the very sort of like holistic care of medicine, focusing on all aspects of the patient to be able to identify how best to help them going forward. And so what do you do on your normal day as a social prescriber?
Very varied. No day is ever the same. So if I went through a typical day, first thing I would do is check the practice that I'm on. So again, different areas allocate their time in different ways. So for us in the north, I had set days at set GP practices on a rolling rota. So I will check my GP practice, see if there's any new referrals, and look at what the requirements are, add them to my referral list. If I've got booked in calls, so I'll have pre-booked in calls, patients already been sent a message, or previous phone call arrangements to call on a day, I will line up to contact those in the order that it's needed. Or I may do ad hoc calls depending on new referrals that have come through and the need for that. So that's the very, very start of my day, just the administration element of the role. And then I work on to my clinic, and I will systematically call people throughout the day and identify and address what their issues are. There's no set time for our calls, so most GP appointments or clinical appointments are 10-20 minutes long as a sort of rule of thumb. So ours can be 30 minutes to an hour. We don't generally try to go over that hour because there may become some repetitiveness, but it depends on the call and very much the individual. Some people want a quick sort of 10-15 minute call, done, call me back another day, that's absolutely fine. Other people want to get everything off the plate in one go and do that real whole holistic approach to see what all of the issues are and then focus on what is the main issue, what's causing the most stress. So it's very, very, it moves and changes throughout the day depending on the patients that we've got booked in.
Okay, and what are some of like the commonest issues that you deal with on an average day?
I would say when we look at our data and reasons for referral in, housing is one of our biggest issues. So people are stressed because there's an issue with the property that they're living in, they may be being evicted for whatever reason, there may be problems with landlords, neighbours, etc, etc. So all of these elements can cause stress, anxiety, depression. So the patients will usually contact the GP practice for an appointment with a GP, or to raise it with the ladies on reception, or maybe a conversation with a nurse or other practitioner that they've come in to see. So what generally happens is, if it's picked up at any point that there's this underlying social issue, that person will be referred to us.
Yeah.
And then we'll pick that up. So housing is one of our biggest ones. Next would be mental health. So again, that anxiety, depression, we support with low level anxiety, depression, but it's finding the root cause of it.
Yeah.
That isn't a medical issue. And then we'll work with that patient to see what support's available. A lot of ours is community based.
Yeah.
So we don't really look at secondary, because that usually is where the GPs have stepped in and done what they need to do. We're more primary, we can do access to primary mental health support or the local community services that are available as well. So again, it's finding what best meets that person's needs.
Yeah.
And then I'd say our third tier would probably be social isolation and activities. So we do have a large number of people who are socially isolated for a number of reasons. It could be that recent health issues means that their ability to go out has changed, they may have lost confidence, there could be a bereavement and they've lost a long-term relative, friend, loved one, and that's had an impact. It could be that they don't know what's available, they're new to the area. So that's another big one that we do. So we have that long conversation with the person about what the barriers are, why, if they can't go out, why can't they go out, or do they not know what's available, and then we find out everything that we need to know and provide that patient with that information and go from there.
Oh, that's brilliant.
So them are just the three main ones.
Yes, but it's still that's the top three are still
so
a lot that you do, and I'm sure it helps them a lot.
Yeah. If I went through the some of the overall, so I won't go through, those are the main three ones. So other ones that we deal with are care needs. So person's care has changed. Independent living is a big one. So access to equipment, adaptations to properties, all that kind of stuff. We will support getting the right people. We do bereavement support. We do financial benefits. I do cancer monitoring support calls from a non-clinical point of view, so I do quite a lot of those. We do weight management, we do work well calls, which is employment support, we do access to education, and anything else really that comes up. There's not a lot that we would say we can't help with, or we won't be able to find something, service or person that we can get someone in contact with to help with any issue.
No, that's brilliant. I'm sure they really enjoy that care and they feel well supported. And so what do you enjoy most about being a social prescriber?
Helping people. Helping people. It seems a cliche, but my background's health and social care, so I've been a carer for many, many years as a background. So I've always enjoyed, that's the most fulfilling I get, is knowing that I've helped someone, small way, big way, life changing. Just knowing that I've helped with that stepping stone to get towards what the person wants in a goal is really what gives me satisfaction from my role. So I would say out of all, it is helping people that I enjoy most.
Oh, that's brilliant. And so maybe following on from that as well, so how does one become a social prescriber?
So there's lots of different ways and avenues. So social prescribers is a relatively new term that's coming through, but there are other similar roles to social prescribing. That is social prescribing, just not called social prescribing. But the sort of desirable elements is to have a knowledge of health and social care, or support with social issues. So as I said, background with housing would be supportive benefits, care and support needs. Having qualifications in those areas as well helps. So low levels 2s and 3s is always obviously going to be a need there. But I think it's the enthusiasm as well to want to help and support people, and it's I think the other side of it as well would be looking outside the box sometimes.
Yeah.
So having that ability to problem solve is always good. Again, it's not something essential, but it's something that can be learnt within the role. So I think if someone has an enthusiasm to want to support people, can be work as a team or work as an individual, that's always a useful skill to have. And just wanting to maybe widen your own knowledge, expand beyond your own experience, or move careers is always a good one, so shift across.
I think that's a lot with healthcare roles, isn't it? It's very developing your knowledge, just continually developing it. And just want to go back to where you mentioned that there were some similar roles that they do similar but not quite called social prescribers. Do you know a couple of what their names are?
So care navigators used to be what are social prescribers now. There's also I'm trying to think of the ones that are in the community. So WHO has their care champions. They're another service, so that's for tenants that are WHG tenants. Then there are Making Connections has social prescribers, and there's sort of social prescriber care navigators as well, so quite similar. I'm trying to think of other specific roles, but I mean you can go to wider organisations like dementia support services. Most of theirs are like dementia support workers, but that support worker is actually a social prescriber. So it can completely be something totally different and disconnected. We have community link workers. Again, it's very similar to social prescribing, and it's all about linking and signposting and referring people into services that are going to support them. So most community services will have some element of social prescribing on top of what they're already doing, but just not accredited towards social prescribing. So it's one of those that we've been doing it secretly for years, just never put a name on it.
And now we've like the official name and the title. But no, it's brilliant. It sounds like you all do so much work, and it does really benefit us as like GPs, healthcare professionals, and patients as well. What would you say are the biggest challenges of being a social prescriber?
I think one of the biggest challenges is going to be accessing the services that people need. There are limitations. There was a big change after COVID. So previously there were lots of like home support services or befriending and friendship, where we've got, say, a big example is housebound patients who can't go out. So their only option would be for home befriending visiting services to come once a week. That kind of all stopped after COVID, and trying to get that back in place for services has been a real challenge. The funding's no longer there. The adapted services are usually preferred by some people, so they do phone befriending, or there's online community access now, so most people have got a laptop or something at home, or one of the iPads or something that they use to connect outside without having to have people come in. So the alternatives that were put in place during COVID are seen as a better option. So the home visiting services are now non-existent. So that's a big challenge, because we do have a proportion of patients who can't go out. They are bedbound for whatever reason, or housebound for whatever reason. So we're always sort of talking to the community services that we come into contact with a lot, and obviously me within my senior role, I do talk to people who are higher up on the delivery of those services, and are constantly championing to try and get that service provision put back in place. There are some things that have moved forward. So for us locally in the north of Walsall, one of our local community support centres, the Istanbul Centre, have just set up a pilot scheme where they go out and visit someone for 12 weeks at home, with the encouragement where they can to get people back out into accessing community-based services. So people who've lost confidence, had falls, have had a health scare or health issue, or anything else that sort of stopped them going out. So that is working really well for the majority of people, except for those that are bedbound who can't actually get off the bed. So we still have a little area of patients that we do struggle to provide the highest level of support or access to support. So we do keep championing for that. So that's one area I would say is the biggest challenge. Most every areas are pretty smooth sailing.
Yeah.
We find something by hook or by crook, as they say. We do usually find a service or support or access. I think the only thing is if it's online, that would be the only problem. If it's an online support only, we do have some people who aren't tech savvy or don't like technology, and that's absolutely fine. So they would prefer face-to-face groups, but some of the services that are nationally based haven't got a local service. So then it's contacting that service to see if there's any sort of idea about moving into our area, or if there's anything that can be done like through their service, maybe expanding it, but it does depend on location, because a lot of national services may be London based and it's a bit then far of a stretch. But we still try and find some way to eradicate barriers where we can, and we'll always keep pushing and championing for changes that need to be made to make sure that a wider variety of support is available for patients that are referred in.
Oh, that's brilliant. And then obviously, like, well, when I'm referring someone, I obviously have the rough idea where it's like you send a task with some like the details of what I need the patient reviewing for. Do you have any tips for us as like the other healthcare professionals for what you ideally would like in those referrals to help it be a bit more streamlined? So,
because we work across different PCNs, so us in the north, the way we do it is we have an EMIS template that's embedded into the system. So what our practitioners do is they pop on there, fill out the referral form. If they can't fit everything they want into the referral form, they save it, and then they will go and add more in before saving the document again and then task us. In regards to information needed, a lot of the time it's already in your consultation. So if you've already identified, this person's come to me for anxiety, depression, while in the consultation they've disclosed that they have a housing issue or a financial issue that's impact, you can put that in to see my consultation detailed notes about issues patients having. We don't want to add to your workload. We know as doctors and clinical practitioners you are very busy, so we don't want to add to the workload. And what we'll say in our area in the north, some people don't know where to find our templates, or it's easier just to send us a task, and that's fine. We'll just then create the referral for you from your task. So again, if you're struggling, just put, I can't find the template, here's what I need support with, that's fine. Sometimes a patient may have mentioned something that the doctor hasn't felt or the clinician hasn't felt is relevant to put in the patient's notes. So they'll just send that as extra in a task. So I referred this patient in. They did mention this, it wasn't relevant to go into our conversation at this point. Or the patient may say, can you not put it in my notes? We do get that on occasion with domestic violence patients. So that's understandable. We know that we can hide consultations and have them appear offline. But if a patient's mentioned something you haven't put in because of domestic violence concerns, patients disclose this, has asked for it not to go into a written document at this point, or you've marked it as safe. Depends on what has been disclosed and what you've got to do within your role, obviously, under safeguarding. But we will just get some ad hoc messages. So I'd say the main keys is what they identified, reason for referral. So if it's a housing issue, you can just put housing issues, they've got damp in the property, told me that they're being evicted. If they're being evicted, please find out the eviction date.
Okay, yes.
Because it will prioritise that person's call. If they're being evicted next week, for me in the north, I might not be in that surgery till the week after, around the eviction time, and it doesn't give me enough time to sort of put things in place to try and get the right services involved, to clarify the eviction's legal and or stop the eviction in its track, which sometimes does happen because patients don't realise if a landlord issues you with an eviction notice, it's not actually an official eviction notice till it's gone through the court. So we know this. We don't expect doctors and clinical staff to know this, but this is our first thing that we do. So if you know they're being evicted and you've got an eviction date, write it in. Same as if they come for benefit support, they want to apply for PIP or attendance allowance. If they've got the form, then we need to know what's the return date on the form, because again we may need to prioritise the call to get them referred in or access to a service because once they've lapsed that return time, they have to start the process all over again.
Okay.
So it reduces frustration for the patient. What else would I say? Sort of key areas we need to know. If anyone else is sort of impacted by it as well. So I was going to say they've got problems with neighbours, and they've already spoken to the police, and they've already gone through neighbourhood and whichever else. You can let us know that.
Yeah.
You know, anything they want to really give, anything you feel, even if you feel that you've gone over the top of the referral, more is always better.
Yeah.
We will always read through everything that's given to us anyway.
Yeah.
And the more we know, the more we can sort of check in, so the patient also doesn't feel that they're having to repeat everything they've told you. So what we do on a referral, for example, if I have a referral that comes through and just says housing issue, when I talk to that patient, all I can say is housing issue.
Yeah.
If you've told me that the housing issue is they're being evicted on the so-and-so date, they live with children, they're really worried about what's going to happen, I can read that referral out. We already know the starting block, and then I could go from there.
Yeah.
Patient knows that they've been listened to by the person they've spoken to, but then I'm already up to speed on what's happening.
Yeah.
So I can just hit the ground running and say, right, this is what we can do, this is what I can do today. Do you know what I mean?
Yeah, exactly. It's like what I do for GP with patients. I like to be informed as much as possible, so I can be like, so they know I care about them and listen to them, and be focused on the main problem to get that tackled for them.
Yeah.
And then sort of my last question is your biggest joys of being a social prescriber.
I think for me, it's because I was one of the first social prescribers for the PCM, so there was 8 of us that started back in 2020 when COVID hit. So I think seeing how the service has progressed over the 5 years I've been here, I think seeing that, you know, when we first started, nobody was really sure what social prescribers did, what we could support with. So building on those professional relationships within each individual surgery, and to the wider community as well. So in my senior role, I do go on a lot of external partnership meetings, and you know, we're now becoming a well-established link support for GP practices. You know, and it's evolved further as well. So where the majority of ours were coming through as like a list for a particular topic. So, you know, during COVID, we had COVID lists, those patients that couldn't leave the property, shielded patients. So it evolved from that, and we now get referrals that are coming in that are specifically been identified. Some of them are identified from a reception conversation when the person first contacts the surgery, or an Accurix. You know, the person sent in a message saying these are my issues, and they can come straight to us. So we're saving clinical time there, because there's not much a clinician can do for a housing issue or access to benefits and finances. So we know that we're then helping there, so that people who are waiting for appointments for medical problems that we can't deal with are getting that access, and then we're taking people that don't require the medical input. So that's been quite good to see, and you know, we've seen our referral numbers increase year after year after year, so the service is getting more well known, so that's good as well. And I think just the interrelationships with the GPs, and knowing that people will approach, as I say, we support anyone within the practice, so we have adult questions sent through to us about patients, clarification about roles, and what we can and can't support with. And it's just that openness, and we do, you know, we're valued within the practices that we support, so that's a big part to it, because I think our role's very unique to what we provide, and just feeling part of the wider sort of PCN team is lovely.
That's brilliant. But yeah, I think that is all my questions for today, and I just wanted to thank you so much for coming on. I can't say for everyone online, but I've learned so much today, and it's really helpful information that I'm going to apply to my practice going forward as well. But again, thank you so much for coming on the show.
No problem.
Well, that's it for today's video. I hope you've enjoyed it and learned something new. Don't forget to like, comment and subscribe, so I know that you're enjoying this content. I'm also on Instagram, which is up here. It's the same name as my YouTube channel, GP Made Easy. Or if you prefer, you can reach me by email, which is up on this side. Well, I hope you guys have an amazing week, and I will see you in the next video.